Welcome to Health Law Talk, presented by Shahardy Sherman Williams. Health law broken down through expert discussion, real client issues, and real-life experiences. Breaking barriers to understanding complex healthcare issues is our job.
And good morning, everyone. Welcome to another edition of Health Law Talk here at Shahardy Sherman Williams. Conrad Meyer, Rory Bellina, your leading healthcare lawyers who pioneering everything healthcare, right, Rory?
It's a good description. Very good description.
And today in the studio, we have a wonderful guest. We have Dr. Jamie Kuo.
Hello, thank you for having me.
That's great. We're happy to have you. And I got to tell you, it's fun because for our listeners out there, I taught Jamie in law school.
Well, not law school, remember. It's
the
master's
in
I don't want
healthcare.
to misrepresent myself.
Yes, that's correct. So forgive me. Yes, but she was in our health law class, and Jamie has wonderfully decided to come on the show today. Really got some good stuff going on, Jamie. How are you doing? What's going on in your world?
I'm doing well. I'm super busy like everybody else in the world. I'm still getting my master's degree, and the reason why you think that I'm in law school is because the master's program is in the Loyola Law School.
Right.
So I'm still doing that right now. I'm taking 6 hours this semester. I'm still working full time. I'm an ER doctor, and I'm doing a lot of my advocacy, which is what we're going to talk about today.
That's great. So let's talk about that. ER doctor. I mean, that's a big deal. I mean, my wife's an ER physician, so I know how terribly tough and stressful that is. What is that like? I mean, how long you been doing that? Where are you? If you're comfortable saying that, tell me about that role in terms of your professional career.
Yeah. Oh, exactly, for sure. So I graduated from LSU Medical School in 2007, and Hurricane Katrina happened during my third year. So my husband and I said, "Oh, let's go away for a few years. Let's go have some fun." So we did residency in Charleston, South Carolina.
Nice.
And honestly, we probably would have stayed there, but my husband became disabled. So we moved home about 6 years. He got sick about a year after he started working. So we wanted to be closer to family, so we moved back. And I've been working in the community since 2013. So I've been practicing, for about, 15 years.
That's a long time.
Yeah, it is a long time. And you were asking what's ER like. We ER doctors see acute unscheduled care patients, right? So patients that are having acute problems and they don't have an appointment with the doctor, so they come to the ER, right?
Right.
And then, of course, we see the patients that are sick and literally dying.
Absolutely.
Right? And it's hard, but, I feel like my career has prepared me for what I'm doing right now. Because as an ER doctor, I literally all day am advocating for patients, whether it's a homeless patient that needs to go to a shelter. We help set that up for some homeless patients. Whether it's a person who has an opiate addiction and they want to go to rehabilitation or recovery, we can help them set them up. And then, just the patients, the 25% of the patients that we admit to the hospital, we've got to advocate to their consultants and their physicians that they get admitted to. So, all day long, I'm talking to people. I've learned how to talk to all different kinds of people, right? Like I take care of CEOs.
And that's a gift. That's a real gift to do that. I mean, being able to talk to everybody, you really have to have a patience, I would think, right? It's hard to do sometimes.
It is. And what's interesting, when I was a little younger and more egotistical, I was probably a little more stubborn and hard-headed and probably had a harder time. But as I've gotten older, I've just realized that if I just keep the focus on the patient when I'm at work, I don't lose. Like whether I'm, fighting for something for them in the community or even, arguing with a doctor about what the appropriate care is. I shouldn't say arguing, but, spirited conversation, I guess. If I keep the focus on the patient, we all win as long as we're doing what's best for them. And that's just what I've learned to do.
I was just talking with Conrad before the show when we were prepping. I think you're the first ER doc that we've had on the show. We've had a lot of doctors, so I just want to spend a few minutes, not a lot of time because we could spend a whole episode on what the past 2 years have been like for you. What was it like?
Oh, that's a good
moving
question.
out of that. I promise. Give me a 2-minute answer on this, and then we could pivot off.
We could literally do a whole episode on that.
Sure, I'm sure. Could. So it was personally hard for me because my husband is disabled. He's immunocompromised and he's on oxygen. So I'm one of those doctors who literally, and I don't want to sound funny about this, but I'm not an anxious person, but that was one of the first times in my life and my career where I was literally at work and my partners were having to talk me down because I was so nervous because we have a child, we have a 12-year-old. So there were all these, and at the beginning, so many healthy people were dying, right? It was so virulent and so deadly that, one, I was worried I was going to catch it and I was going to die. Another thing was that I was worried about was I was going to catch it and bring it home to my husband and he was going to die. And then we were going to orphan my son. I actually was one of those doctors that moved out of my house.
Oh, wow.
For a few months, yeah.
Okay.
And I had some really nice friends who donated their Airbnbs to me or
That's
some condo
nice.
oh yes, people really came out and helped me. And then we just kind of went wild, buying supplies. Even my family is from Lafayette and we do industrial insulating. Not
Right.
me, but my family does.
Right.
And so my brother has all these industrial accounts and he started buying those, those coveralls that would cover the whole head and the body.
Yes,
He bought
yeah.
a bunch of those for us and donated to them. And we got all these masks and I was so active on social media, which I actually usually am not, but just posting every day, like, everybody, you got to do this and you got to come donate your mask to us, blah, blah, blah. And then, taking care of the patients was pretty frightening, because they're looking at you and they were literally looking at me like you are right now, but their oxygen levels are in the 40s, which is...
That's not good.
Oh, no. I mean, your oxygen level should be between 93 to 100%.
Right.
They were in the 40s. And so when we would have to put the breathing tubes, because remember, there was a whole fear of the ventilator shortage.
Right,
Yeah.
right.
We were ventilating everybody. You had to do your procedure so fast and you had to be so confident in it to do it that... I had sweat going to my back numerous times.
Wow.
But, I was lucky. I don't work at some of the bigger hospitals that were just crazy out the wazoo, patients in the hallway. We were a little more controlled in my hospital, so we had all the supplies that we needed. So
That's good.
Yeah.
I mean, I remember, my wife came home, and I don't like talking too much about my wife, but she's great. We had a whole sterile technique. Like, in other words, when she got in the garage, immediately take off all the clothes. There was a garbage bag waiting. She put it in the garbage bag, walked up, immediately went into the washer, immediately went into the shower. It was a whole thing and we did that for, almost a year. And I can remember that. I went and bought toilet paper. I had toilet paper and paper towels. And people thought I was crazy.
You were a hoarder.
Absolutely. Absolutely.
We did the same thing. I would get undressed on my back porch and everything. And now COVID's not gone. Yes, it's less virulent, but it's still deadly for my family.
Right.
I still mask. Y'all saw me. Y'all came in. I still mask.
Sure.
Oh my gosh. I feel like everybody else. I can't breathe either in it. I don't like wearing it either. But
Well, I hope you don't feel bad because we're not wearing masks.
Yeah,
I hope
y'all are sitting far enough away from me.
Okay, good.
Okay, good.
Yeah.
So how have things been? I guess let's segue into your practice now. Have things, I know there's, normal is not the right phrase, but are things going back to more of your pre-COVID practice?
Yes.
Okay, good.
It is, yeah.
Good.
And we definitely see all this spikes in the COVID and everything as they come. We recently had one and where there's always a few patients in the ER that have it, but I haven't seen anybody in respiratory failure recently. One of my partners said she felt like she saw original strain not too long ago.
Oh, wow.
Where like I was describing, like the patient that's sitting there looking at you, but
Sure.
their levels are in the 40%. So yeah, no, it's feeling,
Good.
it's pretty normal.
So let me pivot back.
Okay.
The journey to law school. How, most doctors I know, I'm sorry, not law school, the masters in law. I get that messed up. And that Roy's looking at me with 4 eyes. Like, Conrad, he didn't go to law school.
I will correct you every time.
I know you will. But so how did, the masters in law or in health law, tell me how that came to be and where did the desire to go for that come from?
I actually love telling this story, and it'll actually come full circle for y'all because When I was in my first semester, you told us about, I was taking Health Law 1, and you told us about this. Oh, you didn't know about this podcast? We had this podcast we've been doing. So I started listening to it. Well, I think y'all's third podcast was about House Bill 495. It's 2021 House Bill 495, introduced by Barry Ivy, and it was a scope of practice bill.
I remember this one. Yeah.
I think it was your third. So it was very interesting. Literally the day that you told me about the podcast, that was the podcast that was released that day. So, and that's honestly,
I like it.
House Bill 495 is what really started my journey with all of this advocacy. So, you know, in the healthcare arena, we have a lot of people that take care of patients, right? We have physicians, nurse practitioners, PAs. We have pharmacists in the hospital. We have physical therapists, social workers. You know, there's a lot of different people. So, what?
Yeah, I want to tell you about this. 495. You want to give a quick little for the listeners who didn't listen to that podcast? What is that bill? Why did that trigger the interest?
Yeah. So 495 was asking for independent practice for nurse practitioners after a certain amount of time.
The mid-levels, correct.
Yes.
Okay, your APPs.
Yeah. So I call them non-physician practitioners. I think that's a more accepted terminology because that's actually what the federal government refers to as nurse practitioners and PAs.
As a non-physician practitioner?
They're non-physician practitioner.
Okay.
Yeah. So we think that's our accepted terminology for
Got it.
that.
Okay.
Mid-levels, because I have a lot of friends that are nurse practitioners and PAs.
Right.
Mid-levels they feel is a little derogatory towards them, so I really try not to use that word.
Okay. I did not know that.
Good to know.
We used to back in the day, and I even slipped because I used that word.
I thought APP was the one, like advanced practice provider. That was sort of what we were told. But anyway,
that's just kind of a word that hospitals have made up. But I feel like every hospital, the hospitals around here definitely say APP.
Right.
Okay.
One of the big hospitals.
Okay.
We have a lot of word salad in healthcare.
We surely do. But the terminology that is accepted by CMS is non-physician practitioner.
Got it. Okay.
Good to know.
Good to know.
Okay, so the bill was asking for independent practice, and I've been practicing for 15 years, and at the time I'd been practicing for 13 years. I've worked with a lot of nurse practitioners.
Right.
I've worked with a lot of physician's assistants, and physician assistant. See, you got to make sure with the terminology because that is also derogatory if you call them physician's assistant. They're not a physician's assistant. They're physician assistants.
Okay.
Have y'all made that?
I have not heard that.
It's
I've heard
really
physician extenders. I've heard of mid-levels. Now the non-physician practitioner.
Yeah.
I've heard of all that, but I've not heard of that.
Well, I try to be sensitive because some of the topics that I focus on are not personal, and I'm not trying to be derogatory. Sure. So I just try to be respectful about how I talk about it.
I totally agree. Very diplomatic.
Yeah. So, right, because this is not personal.
No.
Right? How I feel is not personal. My focus is the patient. So the bill was asking for independent practice for nurse practitioners. Mm-hmm. And, I kind of looked back and said, gosh, I don't think this is safe.
Right.
In this bill, it had always been kind of floating around. I had even been hearing about nurse practitioners and PAs and this, quote unquote, they're going to take your jobs and all that, kind of negative talking points. But I had always kind of ignored it. I wasn't really paying attention. My head was in my books. I was just working, keeping my head down. But, when I saw this bill, I said, I don't think this is safe. And I'm going to tell y'all why. Mm-hmm. I've worked side by side with a lot of nurse practitioners and PAs. I have trained a lot of nurse practitioners and PAs, whether they are freshly out of graduation or mid-career and making a change. I have been a recipient of the care of nurse practitioners and PAs, both me and my husband. So me as a direct patient, but also as a caregiver. And then now I work for the federal government. So now I work with them in a capacity where they already have independent practice. So I said, look, I really feel like I know a lot about this, and I don't think it's safe. I do feel like nurse practitioners and physician's assistants have a role in healthcare, but I feel like they need to be supervised. So, I was watching House Bill 495, and it ended up dying in the Senate.
It did.
Right.
Yeah.
It didn't make it.
But what sparked all this advocacy was I started watching every single committee hearing meeting, And I was blown away. I was blown away at
So you watch those hearing meetings?
I watched them.
They're very
The
boring.
debates. Oh my gosh.
Wow.
They're very boring.
Whether it was health and welfare, and then through that you start going, oh, well, I'm interested in this bill. I'm interested. So you start watching
Right.
all the committees, and then you kind of know how they all operate. And then I would watch the floor debates, right? And the way I felt was, gosh, these legislators. Well, first before I said that, I love state level politics because I really feel like our state legislators, they live in their districts. You know,
Yeah.
they don't live in D.C., so they truly care.
Right.
Right?
Right.
And I felt like I just realized that they don't really understand a lot of the bills that they're passing or not passing.
Right.
Because
I would agree with that.
some of them, if you look at health and welfare committees,
Right.
some of them are lawyers. Right. Some of them are some of them are.
Well, their
nonprofit.
backgrounds aren't in healthcare.
They're not healthcare,
Right.
so they don't truly understand how these bills affect patients at the bedside.
And you have a lot of career politicians in Baton Rouge that you have been there for so long that they don't really understand or know. You know.
And even at the hearings, though, Rory, I mean, because you got different interest groups, pitching, right? Whatever the bill is on the table, right, at the
Sure.
committee level. So you might have a hospital or the state medical society or whatever lobbying group is pitching these guys, the legislators. So
Yeah.
I agree
Yeah.
with it. I've seen it. It's terrifying.
Yeah. So by the end of that session, I said, "Oh my goodness!"
Right.
I was like, "Patients need an advocate, and it's going to be me." So, but I felt like I have time. Like I'm an ER doctor. I do a lot of shift work. So I have just like someday, like this week, I have Monday, Tuesday, Wednesday, and Thursday off because I'm working this weekend. So
Got
I
it.
have time to do this kind of outreach. My specialty has taught me how to be an advocate. So it kind of comes naturally to me now, being able to talk to people and advocate for the patients.
I can see that in you.
Thank you. But then I said, well, God, I want to go to law school. So I started researching law school, and honestly, with the disabled husband and
Right.
the son and the full-time job, I really couldn't. But Loyola had this master's in healthcare and master's in health law and administration, and I said I'm going to do that. It's a master's program, it's 30 hours, and I'm still going to be able to really focus on the classes that will help me. And it's been amazing. It's been absolutely
Awesome.
amazing.
So
And we were the first class. I mean, were we
Yeah.
the first class?
Yes.
So,
Yeah.
so I have to ask, and you're in front of me now. Did you like the class? Did we do a good job?
Oh, I loved it. I loved it. It was a little chaotic because, Bo taught on Mondays and you taught on Wednesdays.
Yeah.
So you would have to
Shift.
switch your brain, but at the end, everything really came together and it was great. Oh, you know what? I'm a member of the American College of Emergency Physicians.
Yes.
And this past year, I was a counselor where, you go and you make rules for the society and everything.
Yes.
Okay. I actually introduced a resolution to ask them to support, basically give legal advice to new graduates on contract negotiations.
That's great.
Yeah.
That's really good.
Yeah.
That's really good.
That's really good.
It
See?
didn't get, and that really stems from you because when I was in your class going,
Yeah.
I've never hired a lawyer for any of my contracts. I got really lucky.
Yeah, sure.
That I didn't get trapped anywhere.
Right.
But it was after taking your class that I said, we need more representations. Physicians are, we got the tunnel vision. We're way too into our
Right.
books. We're not paying attention to anything. Physicians are notoriously bad about money. Notoriously bad.
Very true. We can agree to that, right,
Yeah.
I
Rory?
agree with
Yeah,
that.
I'm sure y'all
Conrad's
can,
got
yeah.
personal experience from his
Yeah.
wife, I'm sure.
Yeah.
No, my wife does a good job.
No, she knows. She's all knowing.
She's
all
on
knowing.
ball. So wait, so that was a very good experience for you, and now, so taking that experience, what have you done to further the advocacy? Where are you now? What's going on now?
Yeah. So we ended up, I'm not the only physician who feels this way.
Okay.
Right. A lot of physicians woke up that year and we said, gosh, we really need to advocate for the patients. So 3 of us, interesting enough, 3 ER doctors. I guess we just have more time during the week. Started a nonprofit. It's called Louisiana Physicians for Patients. And we decided we're just going to advocate for the patients, So we raised money. And literally, I'm talking about cold calling my friends and just going down like, hey, I'm starting this group. We're going to hire a lobbyist. And, I'll go on a little tangent right there. I love our lobbyists.
Right.
I think lobbyists have a very negative reputation in general.
I agree with that.
But, I can't live at the Capitol and contact every single one of them. And if you really, I spent at least one day a week at the Capitol this past week, doing Physician of the Day and also just going to meet with my legislators and everything. And if you meet the lobbyists, they're wonderful. They're nice. They're just doing a job. They're just spreading your message for you because you're at work.
Right.
You know.
Right.
So what's the overall message of the nonprofit?
Yeah. So patients first.
Okay.
Patient safety. That is the main thing. So we started the nonprofit. We started that in February. We raised money to hire a lobbyist. And what we've been doing is we're trying to educate the legislator. So the goal has not changed, right? So that's how I originally felt, was I needed to educate the legislator. So what we've been doing is we've just been meeting with as many of them as possible.
Okay.
Whether it's bringing them to lunch, and I even brought all my stuff today to show y'all if y'all weren't interested. But, we kind of showed them the data of why they should or should not be voting a certain way.
Okay.
And all the data that we bring is very patient focused.
Okay.
So we talk about like quality, cost, outcomes, mortality.
So are you having to do this every time a bill is introduced?
Yes.
Where you get a draft of that first bill when it's read, and then you say, okay, we're good with this one. We want to tackle this one. We hate this one. Is that kind of what the process of the nonprofit is?
It is, yes. And, we're so small. We don't even really have a membership yet.
Sure.
We're not completely organized because we're brand new. We just started, 8 months ago. But yeah, that's what we did. When the bills all got registered at sometime in March, we had a Zoom together and said, okay, these are the bills of interest that affect medical care. We're going to either support these or oppose other ones. Yeah.
Okay. So let me ask you this. So I know that the State Medical Society has its own lobbyist. Have they reached out to you? Have you interacted with LSMS?
Yeah. So part of my goal is to unite all physicians across the state, and not every physician is a member of LSMS.
Agree. Yeah.
So I joined LSMS. I joined the American Medical Association. I joined ASAP. I ended up joining every group because I said, if we, this is probably the third time I'm saying this, doctors are not paying attention. Like, they're like this. So I'm literally on my phone finding doctors in Lake Charles, finding doctors in Alexandria, finding doctors in the country, and, in whatever rural area, and saying, hey, this is the message, this is what's going on. And they're like, what? We had no idea. Or they say, oh, yeah, we know, we're on it. And then, but yeah, so I am in touch with LSMS. I actually spoke to the lobbyist yesterday, and we updated.
Wow.
I've been very clear. I'm not competing with anybody, right? Like, if I want to work for the patient, I've got to work with everybody for the patient, right? So if LSMS wants me to, we have this Facebook group with physicians. It's called Louisiana Physicians for Patients, but and it's only physicians in the group. And if LSMS wants us to publish something, we publish it for them.
Okay.
That's great.
Can you walk the listeners through a process of, you gave an example on the House bill from last year, but what's a process look like if something comes out that you decide collectively you don't like, or you think you need to go educate everyone in Baton Rouge about? Okay.
So I'll talk about there were two nurse practitioner bills. One was introduced in the Senate and one was introduced in the House. Neither one removed. Neither one got moved at all. Like, they weren't even presented in committee. Okay. There was a physician assistant bill, and I'll go into detail about that one, everything that we did. And then there was also a pharmacy bill where they were wanting to diagnose. No, actually, that was the one thing they didn't ask to do. They wanted to prescribe medicine, order labs. They basically wanted to practice medicine.
Okay.
And leave one step out, which we didn't support.
Okay.
That one died in committee too.
Got it.
It got discussed a few times, but it also died. Okay, so the PA bill.
Right.
The PAs have a lobby in Louisiana. It's LAPA, Louisiana Association for PAs. I'm pretty sure that's what it stands for. So they want to practice independently, and it's part of their OTP strategy, optimal team practice. Okay, with optimal team practice, they have 4 strategic pillars, and one of them is to have independent practice.
Okay.
So what we do is we kind of, obviously we read the bill and we see what they're asking for, and right now PAs need supervision. Nurse practitioners need collaboration. PAs need supervision. When they are supervised, what happens is the physician that they have their, for lack of a better word, their contract. Well, actually, I think it is a contract.
It is.
Okay. When they go over their contract, the physician that they work with, so let's say ortho, because I know y'all had an orthopedist here who was talking about a mid-level one time. Do you remember that? He was...
I think I do.
Yeah.
I think I do. If it wasn't orthopedic,
you
see, I tell you, she's
I'm trying to remember.
Jamie is really on it. I mean, wow.
Anyways, so I think he was from Colorado or something.
Oh,
he was from out of state. Yeah.
I do know what you're talking about.
Okay, so orthopedists love to have a PA because they do first assist and they'll go.
It was the one on physician contracting. It was the one I did an ortho contract
Yes.
for him, and that's what it
Exactly.
was. Yes,
exactly.
Yes.
Yeah, and that was actually one of my inspirations too for asking for contract help with my national society. But anyway, so they like to use PAs because they can first assist them, and they can start consults for them. For example, I had a spinal tumor when I was a resident, and right now I still follow up in town every few years. And when I go, I will see the physician assistant, and then they get all my history, and then they go speak to the doctor. They go present it to the doctor, the neurosurgeon. And then they make their decision, and the PA comes back and talks to me. But then the physician also comes into the room.
So it's more efficient. It allows you to see more patients.
Exactly. Exactly. And you keep the quality there because the physician still sees
has
you.
oversight.
Okay.
Yes. Okay. So I'm sorry, I go into so many tangents. So we look at the bill. We see what they're asking for. Well, our concern this year was the optimal team practice, right? They were the strategic pillars. One of them is to get the independent practice. Well, what their lobby, I felt, did not reveal was there is an alliance in the PA world called the Physician Assistant Education Alliance. And they wrote a white paper in 2017 talking about optimal team practice. And they said, okay, we agree with 3 out of 4 pillars that y'all suggest. And one of them was, one of the pillars was pay parity. We agree with that. One of them is the PAs wanting their own licensing board instead of being under the BME.
Okay.
And they said, okay, we support that. Another one was promoting team practice. I'm not really sure what the details of that was, but they said, yes, we agree with that.
Right.
The one thing that they said, the 4th pillar, which was asking for unsupervised practice, they disagreed with. And they went through all the education, and they said, PA schools do not prepare PAs for independent practice. We oppose this. And so this was written back in 2017. They were saying, we don't prepare them for that. The way that the PA body was built, or the education was built, was that they go under supervision. Like, that's the whole point of the specialty.
Right.
They were like, if we want to have independent practice, we would have to extend we would have to make their education longer. We would have to completely revise all these PA schools in the nation. I don't think y'all realize, they said they did not think that the national bodies realized the unintended consequences of this. And to me, what's the National Association? I think it's called the National PA, the lobby. To me, they ignored it. And they're still pushing it. They still passed it. Yes, okay. They still put it as their resolution. So what I did, because your question, you probably forgot your question because I'm talking so long. But what I did was, hey, they're asking for this, but their own education alliance doesn't approve of this. So I take it.
You did that at the committee level. So you went to the committee and said, hey, guys, ladies, y'all need to see this white paper. I mean, did you sort of bring that to them? I mean, how did you advocate to, I guess, kill the bill? If it was killed, was it killed in committee, or was it? I don't even know if it made it to the floor.
It died on the Senate floor.
Okay. So were you able to get that white paper out to people so they could see that?
Not at the time. I'm doing it now.
Got it.
I'm doing it now. I
know the board's position. I mean, I've talked to people. I mean, I can't speak for the board, but I know that they would very much prefer to have PAs under their umbrella. Yeah.
Well, look, if you're practicing medicine, you should be under a medical board.
Right.
And that's how I feel about physician's assistants, PAs, and that's how I feel about nurse practitioners. If you are practicing medicine, you need to be under the medical board.
So what kind of blowback, or I guess, have you had any negative responses, maybe from the PAs or the NPs?
That was my next call. I'm waiting to hear where's the pushback, or the rubber meets the road.
Yeah.
What's been that like
nasty Facebook messages?
Yeah. Right.
Or did you get doxxed?
Okay, so I do not like to put stuff on my social Facebook stuff because I think social media is so dangerous. And that's why I stay very data focused. I'm like,
Sure.
if you have the data and you focus on the patient, like I said,
Right.
you can't lose, right?
Right.
So, and I'll speak to the nurse practitioners and the PAs. When the PA bill came out, I actually texted like 8 PAs that I know. I said, hey, do you support this? 6 out of 8 of them said no.
Wow.
They were like, we don't know.
Wow.
And they were like, but everyone fears retaliation because
Sure.
a lot of physicians won't even speak out. Physicians that like oppose
Sure.
the unsupervised practice, they're like, oh, I'm afraid my job's going to get mad at me, or I'm afraid
Right.
I'm going to upset this person at work or something. Everyone's afraid to offend everybody. But what I've done is like, my ego is not as important as patient safety, right? You're going to be a patient. You're going to be a patient. I'm going to be a patient. We're all going to be patient. We're all going to be affected by this. So as I feel, as long as I keep my focus on that, then what people have to complain about is irrelevant.
But also, Jamie,
So-
I think this too, though. I mean, shouldn't we be able to have a conversation about this anyway?
Yeah. And I do,
Without having hurt feelings? I mean, shouldn't we be
Yeah.
able to all sit around, whatever the topic is, shouldn't we be able to talk about it?
Exactly. And there's one nurse practitioner that she and I have talked about this several times, and we have, spirited debates about it because she wants the unsupervised practice. And
Well, she
and
can
I'm
always
just-
go to FQHC. She can always go to there and the federal, because there are no supervised
Yeah.
practices there.
Yeah.
But I get what you're saying.
Yeah, and I just told her it's not personal. This is not about you.
Right.
And this is not about me.
Right.
This is about this, and I don't agree with it. And
Right.
somebody needs to speak out. You
Yes.
know?
Okay.
So, and it's going to be me.
Okay.
I like that.
Yeah.
And why wouldn't it be you? I mean, why would? So let me ask you this. So you're 8 months into it. Did you ever think you were going to do this?
No way. I can't believe. I had a revelation. I was literally watching one of the committee hearings, going, "Oh my gosh, like literally pacing
What
back
do
and
you
forth." I
do?
was like, "I've got to do something about
Right.
this." I was like, "I'm starting a Facebook group." That was my first thing. I'm going in, and literally, I just went down. I added every single doctor that I knew to it, and
So let me ask you
and
this.
it took off from there.
How big's the group now? How many members do you have?
We have about 700 members.
Wow.
We don't have 700 members of the nonprofit.
Okay.
Oh,
We have
in the Facebook
We have
group.
700. Yeah. We actually haven't started the membership drive yet because
Okay. Right.
we're still filing right now
Sure.
and building the website and everything. And I do everything myself. Like I spend a lot of money out of my own pocket.
You know who she reminds me of? Dr. Hoyt.
Yeah.
Yes.
Yeah,
I mean,
true.
you
Another guest on the show.
Another guest on the show. So, I mean, the drive, the passion.
Yeah.
I mean, you're just a go-getter.
I'm stubborn. I'm a little stubborn.
No, I mean, I think you're passionate about what you like. I mean, I can hear it in your voice. I mean, Rory, I can see it. We can see it in your emotion, and I think this is a great thing. I mean, who knew a year ago that sitting here today, you're going to have a nonprofit, that you're being a patient advocate. You're getting your master's. I mean, that's just it's very interesting.
Yeah, it's fun, you
Yeah.
know. And a few legislators actually complimented us and said, we really like hearing from y'all because y'all are focused on the patient. Y'all, when we talk to y'all,
It's not about you
It's not about my industry.
or the physicians. It's
Yeah.
about the people.
Yeah.
And I'm sure they get so much from the insurance side and the reimbursement side and the big lobbyists that come in for fighting for whatever it's going to be for Blue Cross or whoever it is.
Mm-hmm.
So coming for a patient perspective, I'm sure they don't get a lot of that.
Yeah,
No.
because when they asked me, I had a conversation with one of them. I was in the hallway at the Capitol, and he goes, "So what do you do?" I said, he was like, "Where do you work?" And I said, "Oh, I work for the federal system." And he goes, "Wait, but they already have unsupervised practice in the federal system." I was like, "Yeah, I know." He was like, "So why are you doing this?" I was like, "Because I'm doing it for the patient. Like, I get nothing out of this."
Right.
You know,
Right.
and that is something that I'm constantly battling. And you probably remember this from class, but I'm constantly defending physicians because it's so easy to vilify physicians and act like they're trying to protect their wallet,
Right.
And trying to, our egos are so big or something.
Right.
Really? Come on. Do you think a neurosurgeon needs to have his ego stroked? The neurosurgeons.
true.
Let me tell you something. The neurosurgeons are some of our biggest supporters.
Let me tell you, we represent. I mean, I represent several neurosurgeons, and I can tell you right now, they need no stroking.
They need no stroking,
None.
And their jobs are not threatened by unsupervised practice.
Right,
you know, why are they supporting us? Because they care about the patient. Right. Because
I think you have a lot. Don't you think you have a lot of doctors who genuinely, when you get down to the marrow in their bones, that's how they really feel?
Oh, absolutely. And the problem is we all go into medicine with that very altruistic, I want to help people attitude. And then you get into it and it's easy to forget and get lost in all the drama of the day, the paperwork, the never ending clicking, the insurance, the prior authorization. I mean, there's just so much that just drags you down. We call it moral injury.
Right.
That it's hard to remember, you know, why you did this.
Sure.
But I know on my hardest days at work, I'll turn to nurses and go, we had a great day. And they're like, oh, you're crazy. And I'm like, no, we saved lives today. Like, don't forget, that's why we're doing this. Like, we got killed and retired and we clicked 1,000 times, you know, but we saved a bunch of lives today. So, and that's why we all went into it. So, people get reminded of that for sure.
So where Louisiana Physicians for Patients right now, currently you're looking at legislation. Mm-hmm. Do you see this expanding into other areas, maybe with even medical legal partnerships, things like that not only help patients from the legislative standpoint, but in other ways?
Oh, absolutely. And we do, you know, I've been talking mainly about scope of practice this whole time. And, you know, let me go back. I said I do everything myself. I don't exactly do everything myself. We do have a core group of people, and I have advocacy partners that we go to the lunches together. I'm just talking about like doing the paperwork and building the website. One of my partners did the website, so I don't want to. If they're listening to this, I don't want to completely take their credit away. I just mean that
it's a team effort.
It's a team effort. I just mean that we don't have an executive director. Like we're just. It's
well, I have you.
Grassroots.
I mean, I would think that you're the executive director.
So. I would think so.
I guess so. But we already.
You have a board?
Not yet because kind of. So one of my partners is the president, another one is the treasurer. So for a nonprofit, you really only need 2 officers. But my partner who's doing the paperwork right now just messaged me like 2 days ago. So hey, do you want to be the vice president? I was like, sure. You know.
There you go.
See, you have a title.
But yeah, so we've already expanded out. We do give opinions on non-competes. We gave opinions because I think there were 2 bills this past year. They didn't move; they stayed in the.
Sure.
We talked about that was another podcast on that one. That's right.
Something that we would like to do is we'd actually like to introduce some proactive bills, some protective bills. Mm-hmm. One of them is transparency. So not a lot of clinics. There are some clinics out there. Well, they'll do like a bait and switch. So you make an appointment. You think you're seeing, you know, Dr. Conrad Meyer.
Right.
And when you get there, you're not seeing Dr. Conrad Meyer. You're seeing their nurse practitioner or their right. So it's a bait and switch, and then there are some nurse practitioners who are introducing themselves as doctor in the clinical setting. And it doesn't always get clarified that they're not a physician.
To me, that's the biggest frustrating thing, I think, for patients is is how you know who's addressing and what terminology they're using. What are they showing the patients?
Yes, exactly. So there is the American.
Because patients don't know, Jan.
They don't know. And right. So that's what we're here for. We're here to try to educate them and try to protect them by passing this proactive legislation. So we're going to try to pass it or introduce it this year, but it's a fiscal year, so I don't know what's going to happen with that.
Right.
But it's transparency in healthcare. It's saying like this is who's working today, this is their credential, and then
interesting. I think that would clear up confusion because patients they just don't know.
Yeah.
They see a white coat, they see a badge.
Yeah.
And if some nurse practitioner or physician assistant says, "Oh, I'm Dr. So-and-so," which in my mind, I think the board might even have. I thought there was issues about you can't say what or you can't hold yourself out to the public.
That is a truth in advertising, and that was law because I know the person who went and
I don't recall. I don't know the law exactly, but I thought there was some rule against you can't hold yourself out as a physician if you're not licensed in the state to practice medicine.
Oh, really?
Yeah.
If you're not,
is that right, Roy? Am I correct on that?
You can't hold yourself. Absolutely.
You cannot hold yourself out
to be a physician if you're not licensed to be a physician. Yeah.
You're violating the Medical Practice Act. So, very interesting. So you got the transparency. Now, is that being proposed right now? I mean, is that already written in committee, or I don't want to get ahead of yourself, and I want to leak anything.
No. I have a bare bones bill because a few states have already passed this.
I got it. And that's even greater.
Yeah,
I mean,
we have model legislation.
That's great.
Perfect.
Yeah, and we would love to introduce a patient bill of rights, so that the patients know what their rights are.
Okay.
So there's one Medicaid.
Is there there's a nursing home bill of rights in Louisiana? I know that, but there's no patient bill of rights in Louisiana. Wow. Okay.
And what would that look like?
It would. The patient would. So if they want to see a physician, they can see a physician. So that would be part of their bill of rights. Like, you have a right to see a physician if you want to see a physician.
Okay.
Especially if somebody pulled like a bait and switch on you.
Right.
Sure.
You have a. I'm blanking on it now. I can pull out
That's
the
all right.
paperwork.
We're not going to hold you to everything in the
that's
bill,
fine.
but I mean, I think so this is the second bill. So transparency is one, and a patient bill of rights. I think you'd have a lot of support if there were commonsensical, patient focused, patient safety, things like that. I think you would get a lot of support because it's almost, you think it's a no brainer. It's a no brainer.
Right. That's how I feel. But y'all know how it is at the Capitol.
Of course.
Things that you think would
That's
be
true.
so
You're going to have
easy.
a lot of big hospital systems fighting you.
Why do we need that?
On that.
We don't need that.
Right. So where do you see this in 5 years if everything
That's a
goes
great question.
the way that you want it to go? You mentioned membership, so you want to do some sort of, I guess, paid membership to help fund these things with physicians paying in?
Yeah, I mean, and it's just to increase. Honestly, we need money for a lobbyist.
Sure.
Because although I was able to go pretty much every week this past year, I'm only one person.
Sure.
Yeah.
And LSMS is there every day. They do a great job. But right now, I feel like I'm flying by the seat of my pants. So I really don't have a 5-year strategy.
Okay.
We're still growing. We're still talking and planning. Like right now we're talking about the Louisiana chapter of ACEP, American College of Emergency Physicians. We have been brainstorming on how to raise money. So we're talking about maybe trying to plan a CME conference so that we can, because it's a big problem actually in the ER world is in the rural areas, like you might not always see a physician.
Sure.
You might just see a nurse practitioner. And, do you want to have some sort of a tractor accident and, not have a board certified emergency physician?
That happened to, not me over the summer. It happened to my son over the summer. Not a tractor accident, but same thing. Rural. Went to a hospital Saturday night. Your typical, what you would expect of an ER in a rural town on Saturday night.
If they're really an ER, they could be just a GP or a PCP or family medicine. I mean, they're not ER.
This was the ER that the paramedics recommended, and it was a nurse practitioner. Knock on wood, everything was great. He did a great job, but had to do a CT scan and radiology and all that. And would I have felt better with an MD or a DO there? Yeah, probably. Yeah. But that's what we were faced with. So
yeah, and look, I mean, I can't say it enough. It's not that I think nurse practitioners and PAs are not good enough to practice. They need supervision. The physician needs to be there for the times that whatever the patient is presenting with is beyond their level of education.
And I think you're going to see there's so many different angles to that, because from the hospital's angle is that in this hospital, they could make them as an independent contractor so they can bill themselves, and they're probably having to pay them much less than an MD or a DO. They want to do it because they want to capture more fees and not have to be underneath the supervision. So I think there's a lot of different people that either want this to happen or don't want it to happen. Probably the patients don't, but I think hospitals are probably okay.
I think hospitals. Well, I mean, you think about this though. If you think about incident to billing, right? I mean, if they want, I would think they would want to have more mid-level, more APPs or.
Right, that's what I'm saying. If I'm a hospital,
so I can capture that incident to at a full 100%, and it's all being done by the APPs.
Yeah, if I'm a hospital and I need to staff an ER, I would rather staff it with an NP than a
because I'm paying less, but I'm still capturing the full pro fee.
Correct.
So okay, so
that was a lot of legal jargon, but that's
No, I hear everything you're saying. I actually agree with you. So and that is what is happening. So, but that's like the tip of the iceberg, right? So the people in the business office are saying, all right, we're gonna hire And this is happening with private equity, which I think private equity is the root of all evil. Like when they move into the hospital systems, costs go up and quality goes down. It is proven. I mean, I have a bunch of data to back that up. Okay. So, but what they're doing is they're saying that they're taking advantage of the nurse practitioners, really, right?
And
they're paying them less to do the same type of work.
They're not putting them in their network, so they're billing the patient out of network.
Oh, really? I didn't know that.
Oh, yeah.
That's a common.
That's the big scheme in ERs.
Yeah.
Is that you have them as an independent contractor. They bill out of network, so the hospital gets to bill their fee.
Well, wait, that's going to end, though, with, come on, it happened this year, the new legislation.
It ended January 1st, where they have to take your
Was that the CARES Act? No, it was, come on, what was that? You know what I'm talking about.
The acronym for it now. I'm drawing a blank.
It's killing me. It started January 1st. You're correct.
Yeah.
There was a transparency, the billing, and they can't. You're in network. You got to stick to network fee. You can't.
Yes, for emergency services.
Like no surprise billing.
That's what it is.
Okay.
Yes. The no surprise. The no surprise act. Thanks, man. Jamie coming to the rescue.
Yeah. Well, we advocated for that last year in DC.
That just started.
Yeah.
That just started. So all that mess that's supposedly going to tie it up.
Yeah.
Correct. You know.
Yeah, so there's a study out of Hattiesburg. There's the Hattiesburg Clinic that they finally showed us the data that physicians all knew was true, but we just didn't have the data to back it up. And they finally published the data for us. So Hattiesburg Clinic is a clinic in Hattiesburg, Mississippi. And, they're cousins, so healthcare is very similar.
Right.
But they are an accountable care organization, which means that they're funded by Medicare, right? And they need to keep quality up and costs down.
Correct.
And if they meet their goals, then they get their bonuses at the
end. Bump.
Right. Okay. So Hattiesburg Clinic is, I don't need to look it up, but they have however many clinics, however many doctors, and they were doing an analysis because they have a business to run, right? Like let's do an analysis and see who needs help and who doesn't. Well, what they found when they did their analysis was the lowest performers were the nurse practitioners and the PAs, and to that point. And I'm sure there were a few doctors.
Right.
Okay. So they found that the nurse practitioners and the PAs, and they had their own patient panels, by the way, meaning like they would see their own patients.
Oh, wow.
They had this contract with a physician, but the physician wasn't seeing them. Well, the CEO, he's done a few interviews, a few like podcasts and stuff like that.
Right.
Where they were under the assumption that the quality would be good and the cost would be good. So that's why they hired them.
But they gave them their own panels.
They gave them their own patient panels, yes. So when they did the analysis, and this is 10 years of information, they found that the nurse practitioners and the PA panels, independent run panels, perform lower in 8 out of 10 quality metrics. And if you care about money,
right,
the nurse practitioners and the PAs cost Medicare $43 per member per month for the affected patient. So when you calculate that out, it doesn't sound like a lot, right? Oh, it's only $43. $10 million a year. And this is just for uncomplicated patients.
And why is that? Why do you think it costs Medicare?
Well, they must have had large panels, and they must have had a tremendous amount of patients, and at that dollar rate, annualized.
Well, they order more consults. They order more tests.
I got it. Some more tests. Okay.
Yes.
But wait, is it's capitated? Is it capitated or is it?
No.
So it's fee for service.
Mm-hmm. I don't know if it's fee for service, but I know it's not capitated.
Because when you say $43 per member per month, I'm thinking in my brain that's a capitated payment. But it's not.
They were billing out to Medicare, costing Medicare $43 more per member per month. And this was just for simple patients. This simple.
Oh, I see. Above that, I got it.
Exactly.
Okay, they were the outlier.
Yeah, because and this is what their data showed. They consult more. Even the consultants were referring to other consultants more in the independent panel. Non-physician practitioners. So what they did was after they did that analysis, starting in 21 or maybe this year, they took away all of their independent panels, and all the panels need to be overseen by a physician now.
Interesting.
And like they said the same thing I said. We value our nurse practitioners. We value our PAs. They just need to be supervised now. That's what's best for the patient. And they said the NPPs at their clinics, like they had 6 months to prepare for it. They took it very well. They weren't offended. Because you can't argue with the data, right?
Interesting.
It's Medicare data.
Right.
Right. So they said it went very well. And, we did have the nurse practitioner lobby and the PA lobby kind of try to brush it away. They actually did that in committee, and I was actually very upset with it because I felt like they misrepresented the study. But they tried to blow it up, and I'm like, if you read the study, it's only 5 pages. It's very clear that patients need physician-led care.
Yeah, I mean, I think, all the physicians I talk to, I guess they're self-interested. Some would say the same thing. Like, there just needs to be oversight.
Yeah.
So that's a very interesting concept. So let me ask you this. So now, you haven't got a full year in. I think we're going to have you back because I would love to see
Follow up.
Oh, without a doubt.
Yeah.
Especially if some interesting bill comes out that you guys think that your organization feels like it needs to be talked about. I would love to have you on so that we could talk through it.
Yeah. I would love that. Yeah. And gosh, we've only been here for 8 months, and sometimes I feel like,
Sure.
Like I said, I'm flying by the seat of my pants. But when I really go back and list what we've done for people, like we had a lunch with the Black Caucus. I organized a listening session with one of the senators and one of the reps to speak to rural health physicians, because it's always about rural. It's always the talking point for the nurse practitioners is access to care.
Right.
Which is not true. It's not true. I keep telling people it's an unfulfilled promise. Like every state, 27 states have passed unsupervised care, and not one of them has improved their rural access to care.
You mean the market penetration in terms of? I got it.
Yes.
That's interesting. So they use access as a goal for independence, but it's really a farce.
It's a farce.
Interesting.
Wow.
Yeah. I can show you the maps. It's and you can do the comparisons. It does not change.
That's pretty amazing.
That is data driven.
You can't. Data doesn't lie.
And then one of the senators on the health, who she introduces a lot of the bills. She'll point out that the VA they do it. They haven't had any problems, but there was I want to say independent practice or unsupervised practice for them was passed. Okay, I don't remember what year it was. Maybe it was 2016. Okay,
right.
Well, in 2014, there was a quality group that looked at all the data for nurse practitioners and their quality, and they asked like very specific questions about outcomes and everything. And
right.
I want to say they started off with like 900 studies, and then when they whittled it down, only 8 studies applied, right? Because you're going to hear the nurse practitioners say, we have all this data. Here's all this data that supports our cause, right? Well, they were only able to use 8 of the articles, and then 8 of the articles, all 8 either were like low to moderate to really no, I'm sorry, I'm blanking on the word. Like the quality of the study. They were low quality studies.
Right.
So they said, even though we're going to tell you what these studies show, it's low quality data, so you can't even really make a decision on it. Well, guess what? The VA passed independent practice 2 years later anyways.
So there's no joy. Well,
yeah.
So we talked a lot about today.
Yeah.
The focus on oversight for nurse practitioners, physician assistants, non-physician providers. Mm-hmm. What other, and we talked a little bit about transparency. Mm-hmm. Are there any other topics that your organization, the Louisiana Physicians for Patients, is looking at? And if it's not, I'm just curious if there's any other things that are on your radar right now, right, for your organization that you want to bring up.
No, everything that we comment on is very I've said it for a dozen. It's very, very, very patient focused. So we did comment on a few like vaccine bills where we felt like it would be detrimental for the patient. So there was one bill. It was they were asking for pharmacists to be able to give vaccines to people of all ages. Like right now, you have to be a certain age to get a vaccine in a pharmacy. Mm-hmm. And we actually opposed that. And it was very mixed. The medical community was very mixed about that. Mm-hmm. But we opposed it because I personally know people who, like Children's Hospital, I think this is great. Children's Hospital has a shop bus to make getting vaccines more available.
Right.
More like they'll go park in, the Walmart parking lot and like, come get your shots,
sure.
Right? I think that's great. But I personally know some people who don't go see their primary care physicians so they don't get their wellness checks, right?
Got it.
And preventive health care is what prevents, medical problems, and that's where a lot of medical problems are found. So if you go every year and you just go get your shot and you don't see your physician and they don't hear that murmur or see that medical problem that you don't, then we felt like it was a danger to patients. So we actually opposed that. So as a broadly, no, there's no specific topic. We kind of address them as they come.
Gotcha.
Yeah.
We're gonna let me ask you this, Jamie. So if someone wants to go to, I know you haven't built it yet. You're saying you're building the website. Yeah. Do you have a domain name or website address that's going to be coming out yet? As if you do, I think it would be very interesting. And if you don't, we can always get that to you later. That's fine. Yeah. We can post it on the
link to the podcast.
Yeah, we could do that too. That'd be great.
It's Louisiana. It's HTTP Louisiana Physicians for Patients dot.
www.louisianaphysiciansforpatients.
It's not www.
It's not.
It's just the HTTP
:// Louisiana Physicians for Patients.com.
Yeah.
Got it. Okay.
Or .org or something. Shame on me.
We'll get it. That's okay.
That's okay. Well, you know what? We'll get it from you. But I want to be able to tell the listeners, if you want to go to the website and look at what your organization is doing for patients, I think that would be something that would be of interest.
Thank you.
Well, Jamie, Rory, any final thoughts for Dr. Kuo?
No, I think we should definitely have you back. Maybe when some bills come out in session, we'd love to hear.
I want Jamie on as a regular here. I mean, she's like a natural.
I would love to do that.
Well, we want to thank you very much for coming down today. It's been a pleasure seeing you. I really enjoyed this. This was really fun, and I'm so happy for you. I mean, this is. I've watched you in the classroom, and now I'm seeing this. It's like I'm very proud.
Thank you so much.
I'm
thanks
very
for
happy.
having me.
Great. We'll look forward to next time. Well, everyone, thank you very much for another episode of Health Law Talk, and we'll post this up pretty soon. I hope Rory and I will get this done, and we look forward to the next episode. Everyone, have a great week. Enjoy.
Thanks for listening to this episode of Health Law Talk, presented by Shahardi Sherman Williams. Please be sure to subscribe to our channel, make sure to give us that 5-star rating, and share with your friends. Shahardi Sherman Williams is providing this podcast as a public service. This podcast is for educational purposes only. This podcast does not constitute legal advice, nor does this podcast establish an attorney-client relationship. Reference to any specific product or entity does not count as an endorsement or recommendation by Shahardi Sherman Williams. The views expressed by guests on the show are their own, and their appearance does not imply an endorsement of them or their entity that they represent. Remember, please consult an attorney for your specific legal issues.